4 del curso de posgrado que estaré llevando junto con la doctora Mayra Ramos. Les comento que nuestro primer ponente es el doctor Craig McClain. Él es gastroenterólogo, catedrático de la Universidad de Louisville y interesantemente dentro de las publicaciones del doctor McClain destaca esta reflexión sobre los aspectos nutricionales del NASH. En particular, las últimas publicaciones abordan mucho el tema de lo que son las dietas, por ejemplo, de estilo muy americano, los del fast food, por supuesto, y la contribución que pueda o no tener, por ejemplo, las dietas ricas en fructosa, con edulcorantes, y yo diría que en general ha hecho una gran contribución en el tema de la reflexión del manejo nutricional. Y por eso su charla estará enfocada a eso, al manejo nutricional del NASH. Bienvenido, doctor McClain.
Thank you very much. And I appreciate the organizers putting on such a wonderful symposium and showing us such great hospitality. It's a pleasure to be here and talk about one of my favorite topics, which is nutrition and liver disease. I have nothing to disclose related to this talk. So, although you would think that everybody would understand that malnutrition is important in liver disease, this is the most recent version of Schiff's liver disease textbook. And this is the first time that there's been a chapter on malnutrition and liver disease as a chapter that we write. Now, I was very impressed yesterday dealing with the young investigators that many of them are already studying malnutrition and liver disease in Mexico, so I think Mexico's ahead of the curve on this. So in the next 20 minutes, I'll talk about the prevalence and implication of malnutrition in alcoholic hepatitis and cirrhosis, the assessment of malnutrition, the causes of malnutrition, and lastly, touch on nutrition support. And I've chosen to go to more advanced liver disease because you've heard about earlier fatty liver disease already, and more advanced liver disease is a place where we have studied it well and have good ideas of how nutritional intervention can impact the disease process. So first, for the prevalence and implications. So as I said, malnutrition's been best studied in severe alcoholic hepatitis and cirrhosis. However, once cirrhosis develops in viral liver disease or NASH, why malnutrition frequently, actually I would say regularly, occurs. So the best studies, again, were early studies that I participated in, Veterans Administration cooperative studies, looking at the prevalence of malnutrition in patients with severe alcoholic hepatitis, many of whom had cirrhosis. And we used simple tests of malnutrition, which, as I'll talk about later, aren't necessarily very good for patients with liver disease, like albumin, for example. But we used one thing, the creatinine to height index, which should be 100% of normal. And here you can see, even in mild alcoholic hepatitis, they were down to 75% of normal and much more decreased with severe liver disease. Now, you can have alterations in macronutrients such as protein, carbohydrate, and fat. And I'll discuss briefly examples of each one of these. First, for protein. If we look at the early VA studies or studies that we're doing today in our NIH-funded DASH consortium studies, the average protein intake of our patients is about 50 to 60 grams of protein a day. But we know that you need at least 85 to stay in positive nitrogen balance. So many of our patients, like this one here, have obvious sarcopenia. But many of our NAFL patients with obesity are also sarcopenic, as shown here. So this guy basically can't get out of bed to change the TV channel. He's using a remote here, but he can't move. And unfortunately, looking around the audience here, many of us are older. So in bone health, 45 years is when you start losing bone mass unless you do something. So many of our cirrhotics are also in this over 45 age group here. Now, this is from a recent review article on sarcopenia, listing all of the causes of sarcopenia. These are all of the things that we see in our cirrhotic patients. So they're older, they have inflammation, they have decreased activity, they have anorexia, they have altered endocrine function with decreased testosterone. So it's not hard to imagine that many of our patients are going to become sarcopenic. What about carbohydrate? Well, you heard about the good, bad, and the ugly. The really ugly in the United States is fructose. And so that's the first thing I always tell my patients is to stay away from sugared pop. So in animal studies, we know that it causes problems, and I'll show you examples of this. And there's extensive human data on the adverse effects of fructose. So I talked about the importance of graduate students. This is a postdoc actually from a foreign country that didn't speak English, came to our laboratory and did these studies. And this is one of the first studies showing the critical importance of fructose in altering gut barrier function. So we fed animals a regular water diet, artificial sweetener, glucose, sucrose, or fructose in their water. And here we've opened their bellies. You can see with glucose or sucrose, they get a lot of adipose tissue. But with fructose, they have some visceral adipose increase, but they have much more fat in the liver. And fat in the liver is the worst place you can have it. So shown here, the fructose animals have more fat, they have more hepatic TNF. And we went on to show that if you fed the fructose fed animals antibiotics, a non-absorbable antibiotic, neomycin, why you could totally protect against the endotoxemia and the fatty liver, showing the importance of the gut-liver interaction with fructose fatty liver. Now, what about fat? So, you've heard a lot about fat in this conference, and different fats are bad in different liver diseases. So in alcoholic liver disease, polyunsaturated fats, and that's the N6 fats, are especially bad. And our consumption of linoleic acid has gone up dramatically, and that's the bad N6 fat over the past century. So in our experimental animal models, why we know that if we feed them a high corn oil diet, why they get worse alcoholic liver disease. And they get these lipid peroxidation products like acrolein and 4-hydroxynonenal and oxidized products of linoleic acid that are highly toxic. And in genetics, we know that both for NAFL and alcohol, that the biggest genetic factors relate to lipid metabolism like PNPLA3. If you've ever seen the American movie Super Size Me, a guy goes to McDonald's and gets supersized every day for a month. And here you can see his weight increase, but more importantly, well, his lipids go up, but his ALT and AST go up dramatically. And that forced him to stop this movie because he was literally killing himself. What about micronutrients? Well, I've listed a whole group of micronutrients that you can become deficient in. And my favorite is zinc. I've studied zinc metabolism since my first federal grant in the 1970s. And in that first study, we showed that people with alcoholic liver disease had lower zinc levels than controls, but those with decompensated liver disease and encephalopathy had the lowest levels. And there were many mechanisms for this, including decreased intake, impaired absorption. And these are the classic skin lesions of zinc deficiency called acrodermatitis that you can see. And I still see probably a patient every other month that has a mild case of this. How do we assess nutritional status? Well, again, it's very tough in liver disease because many of these simple tools that we use are altered by liver disease. But I've listed a group of them here, and I'll highlight ones that I particularly like. So a simple thing, and I talked to some of your young investigators about this yesterday, is hand grip dynamometry. So it's very cheap, and it's a functional status. And so as people regain muscle mass, why their hand grip improves, and that's shown here in actually one of our patients in our alcoholic liver disease study. So in green, you can see his hand grip strength goes up very quickly, and his MELD score comes down more slowly. So functionally, he's improving very quickly. Bioelectric impedance is great. So I think it's really the gold standard. And studies from Europe show that it correlates the best with underwater weighing. And these machines are actually very, very good and relatively inexpensive now. You heard a little bit in previous talks about CT scans. So you can retrospectively pull out CT data and do a cut through L3. And in red, you see muscle mass here, and it's markedly decreased as this patient lost weight. Then there's a thing that I encourage all my house officers to learn how to do, which is the subjective global assessment. And so it's really a bedside examination that includes multiple things like patient history related to weight loss, their dietary intake, and doing a physical exam and just looking at them. And here you can see this patient is very malnourished with a lot of ascites, loss of muscle mass, and obviously decompensated. And here he is a couple years later. He's regained muscle mass, he's lost his ascites. So even if you're decompensated, why, you can improve. What are the major causes of malnutrition? Well, many of our patients, once they develop more advanced liver disease, have anorexia with alterations in taste and smell. A big thing is delayed gastric emptying, and so you need to look at that in your cirrhotic patients. They have bacterial overgrowth, which is very important for multiple complications. They have cytokine effects, which is something that I've studied for 40 years now. And then once they come in the hospital, they have their complications of liver disease, and we fast them for procedures. So in alcohol, we have empty calories. So again, as I discussed yesterday, our people in both our alcohol detox program and in our alcoholic hepatitis studies are drinking about 15 drinks a day. But fructose is also a problem. So in the United States, we have these big cans of pop. This is 290 calories. So it doesn't take long to have, 1,000 or 2,000 empty calories a day in fructose. And here you can see the increase in fructose in the United States parallels our obesity epidemic. What about nutrition support? Well, I love this study. So to my knowledge, this is the first study of any type of therapy intervention in alcoholic liver disease. It was done by Arthur Paytak in 1948, and he brought people into what was a clinical research center, and basically offered them a high-protein, high-calorie diet, which is really against the dogma at the time. And he showed that those patients who came in and did that had a better survival than those patients who did not participate. And so this is really the thing that led to our interest in malnutrition and liver disease. These are data from our VA cooperative studies and where patients were hospitalized for a month period of time. And these patients had an average bilirubin of 17 to 20, sick patients. And those patients who ate less than 1,000 calories a day, almost all of them died. Those that ate more than 3,000 calories a day, almost all of them lived. And so how much they took in voluntary food intake directly correlated with their mortality. So then in Spain, they asked the question, what if we give people extra calories? And they did it by enteral feeding. Would that improve outcome? And so this is a multi-center study from Spain where they looked at enteral nutrition versus steroids. And the first month, the data are the same. Actually, at a year, the people who had gotten the enteral nutrition did better. And this is one of the problems that we worry about with steroids. Do they lead to late infectious complications? Late evening snacks. So this is a very important take-home point. So our patients with cirrhosis have decreased glycogen stores in their liver. And so they go into a fasting mode overnight. If I had a pill to do this, I could fix the obesity problem in the United States. So this is a study from Germany, and it's a fantastic study. So they fed the people a nutritional supplement either at 3 o'clock in the afternoon or at 9 o'clock at night. And the 9 o'clock at night's in the black. So if you feed people a little food at 9 o'clock at night, that prevents that starvation from occurring and maintains muscle mass. What about outpatient dietary counseling? So this is from patients with a variety of types of cirrhosis from Japan. And they either got counseling from their physicians, and we're not very good at it, or they got counseling from a dietitian, and sometimes they were started on branched-chain amino acid supplements. They got late evening snacks, so the dietitians told them to do all the right things. And they had the patients who were counseled by the dietitians had a better survival. Now, I said I love zinc, and so we give all of our patients with cirrhosis 220 milligrams of zinc sulfate a day, which is 50 milligrams of elemental zinc. And we've shown that zinc basically blocks almost all pathways of alcohol-induced liver injury and many other types of liver injury. Other micronutrients are important, like vitamin D. Vitamin D levels are almost always decreased in people with any type of liver disease. Are there special nutritional considerations that we should keep in mind? Well, a lot of my colleagues don't like to put feeding tubes down patients, and the patients don't like this either. But, you know, sometimes you have to force food intake. And so people worry, will the feeding tubes cause GI bleeding? They don't. Do not protein restrict for hepatic encephalopathy. If you restrict intake, all you do is break down more muscle mass instead. So, common mistake. And lastly, more is not always necessarily better. So especially with some micronutrients, like vitamin A, for example, can actually cause liver disease. So in conclusion, patients with alcoholic hepatitis and cirrhosis are frequently, and I would say regularly, malnourished. Traditional nutritional support improves nutrition, and it may improve overall outcome. Nutritional therapy attenuates many of the mechanisms for cirrhosis, including alterations in the gut barrier function. And lastly, nutrition is a frequently overlooked therapy for cirrhosis, although I think in Mexico it looks like you're doing a good job. Thank you very much.
Dr. McClain, could you come here, please?